You tell her, Harshini. I have sent her the link.
So, Jignesh, can we start?
Yes, Pallavi, we
Yeah.
can start.
Okay, so good evening, doctors and my dear colleagues. So today we are having the very first session of the ESI webinar on endometriosis. So with ESI, we are so fortunate to to work with the ESI. So the ESI is a society that are actively working in the endometriosis space. They are very much involved in the academic support for the endometriosis. So in this series, there will be a 12th webinar we are going to have, which are going to cover almost 47 modules. So today we are having a very first session of this ESI webinar, which is the decoding endometriosis from cause to diagnosis. So for this, I welcome Dr. Ramani Devi first. Dr. Ramani Devi, as we all know, it's a very eminent name in the gynecology space. So Dr. Ramani Devi, see there is so much to talk about Dr. Ramani Devi. I would like to highlight few of the things. Dr. Ramani Devi is the president of TNFOG 2024. She was national vice president FOGSI 2020, ICOG governing council member from 2018 to 20, and the chairperson of endometriosis committee of FOGSI from 2014 to 16. So there are so many credentials and the awards that Dr. has with her name. So I would like to invite Dr. Ramani Devi to take this session ahead. Please, Dr. Ramani Devi.
Okay. Good evening, everybody. I have great pleasure in welcoming all the faculties as well as the members who have joined this webinar series on behalf of Endo Society of India. Here with us, we have in absentia Dr. P.D. Mahapatra, who is the president of Endo Society of India, and we have Dr. Pradeep Mitra, who is the secretary for Endo Society India, and today's chairperson, Dr. Uma Velmurugan, and the speakers, Dr. Harshini, Dr. Hepzibah, and Dr. Ashika. So we will be dealing with endometriosis entirely, right from the clinical diagnosis up to the future and the latest advances in endometriosis in a series of 12 webinars. Each webinar will be covering for a period of 2 hours on alternate Tuesdays. So totally we are planning for 12 series of webinars, and soon we will be getting the ICOG credit points for that also. So with this, I welcome all of you to participate in this webinar. And the next person is, as Dr. PDM is not available, Pallavi, can you show the CV of Dr. Pradeep Mitra? Our first is CSA prayer. Okay. Pallavi, you have the ESI prayer with you?
No, ma'am. I thought you will be.
No, we don't have. That's okay. Let us pray God that he should bless us with this series of webinars. Next, get into Dr. Pratipitra's CV. Next. So Dr. Pradeep Mitra is founder, Secretary General of Endometriosis Society India and the past president of Bengal OBGYN Society. He has been working in the field of endometriosis and adenomyosis for the last 23 years, and he has organized so many conferences. In ICE conference in 2025, which was held at Kolkata, was a very, very grand success one. And then he had so many publications and number of books, international faculty in FIGO, AS, AOCOG, SUD conferences, EVOFOC, etc. Past faculty in University of Illinois, Chicago, past faculty of Uchida Hospital, Japan, and he is a visiting experimental endometriosis research fellow in Canada. And he is the principal investigator for so many research projects. And currently we have started the LME project, which is on flow, and he is heading that principal investigator for Indian scientist. So with this introduction, I welcome Dr. Pradeep Mitra to say a few words about Endometriosis Society India.
Thank you, Dr. Ramani, for kind words. May I share the screen? Is it possible?
So, doctor, you want to share the screen? Should I stop
Yeah.
sharing? Yes.
Yeah.
Okay.
Is it? Can you see my screen?
Not yet, sir.
Disable share. It says disable share.
Jignesh, please help. Dr. Pradeep Mitra wants to share this slides from his laptop. Dr. Mitra, even I have your slides. If you are allowed, I can also share those slides about the Endometriosis Society.
Mitra sir, she has the PPT with her, sir. Let her share, sir, if you are finding it difficult.
No, I'm just trying to share it. It should
Okay.
occur because just 1 minute.
Okay.
I've gone to the window. I've slide share and then a window. Then what is the next step?
Click over that PPT, sir. You have joined with the this one, no share option. Then click, the windows will open. Click on the PPT.
PPT.
Join பண்ணிட்டியா? சரி சரி ஏம்மா அந்த லிங்க் சரி நான் உனக்கு அதை இதில் அனுப்பட்டா? Shall I send it by mail? சரி, ஓகே.
Sir, shall I share my screen? Is
Sir,
it okay?
Your screen is visible. Just open the presentation now.
Hello.
Yes, sir. Your screen is visible. Just open the presentation.
I opened it.
We see
Can
the
you
Zoom
see the
screen.
presentation?
We see the Zoom screen, sir.
Can you see my presentation? Welcome to Alcare webinar.
No, sir. We are currently seeing only the browser, your Chrome browser. Sir.
So what should I do? Because it is
Sir,
important for future. Today I can try it for
Sir,
1 minute if possible.
Just stop sharing and share the screen.
Stop sharing.
Yes.
And then share
Then
screen. Okay.
Share. First, you see the first option is the entire screen. Just click it.
Entire screen. Okay.
Okay. And start.
Start.
Share. Oh.
I can see. I've clicked the entire screen, but nothing is open.
Then you have to select the share button.
Correct.
Sorry.
Then you see there is a blue button in share. When you select the entire screen, then downside there is a share. Click on that.
Downside. Downside. Now I see a Chrome tab, window, and entire screen.
Entire screen and share it.
Pallavi, Dr. Bhaskar Pal is also joining. So next to Dr. Pradeep Mitra's talk, we'll welcome Dr. Bhaskar Pal.
Okay, ma'am. Okay.
Huh?
Yeah.
I think, but his
I'll click entire
screen
screen,
is
then
not there,
share.
but anyway, I will introduce.
Yes, sir.
Yes, your screen is about to start, sir.
Just presentation. Open the presentation now. Your screen is visible, sir.
Yeah,
Yes, sir.
Yes,
Make it
sir.
in a full screen.
Full screen. Hmm. Otherwise, you go ahead, sir. Go ahead.
Sir, you are on mute. Just unmute yourself. Your presentation is visible.
Now? Now can you hear me?
Yes, sir. We are
And
here.
presentation is visible?
Yes, sir. Your presentation
Presentation is
visible.
visible?
Ah.
Okay. Now I'm making it in
Yeah.
slide full screen mode.
Okay.
Yes,
Okay.
yes, yes.
Is it
Yes,
okay?
perfect, perfect.
Okay, sir. Perfect.
Okay. Okay. Thank you. Thank you very much. Well, it's a great pleasure for me to be here, to know that it's a big webinar. I mean, the longest one is going to be held under the banner of Endometriosis Society India. And on behalf of my president, Dr. P. Dashwapattar, it is my pleasure to welcome all the speakers, all the participants, and everybody who are joining from anywhere from the country, not only from India, but also anywhere from the globe. So it is a pleasure I've been asked to say a few words on Endometriosis Society India. So, as I already said, this particular course convener of ESI modules, along with Dr. Malaraj and Dr. Harshini. I just highly appreciate, in fact, no word is there to appreciate the people who are the key persons for this particular webinar series, which is so important for everyone who are practicing gynecology and endometriosis. And you have done a great job, which we highly appreciate from the secretariat level. Now, about Endometriosis Society India, here you can see the key person, Dr. B.N. Chakraborty. I never say that he is Dr. late B.N. Chakraborty because he was with us, he is with us, and he will be with us forever. And this Endometriosis Society India is the brainchild of Dr. B.N. Chakraborty, which has been implemented by the key person during that time, the founder president, Dr. Pramod Dashwapatra, and I was one of their assistants. And that is the main part we did. And I always used to remember the 4 important words as told by Dr. B.N. Chakraborty to us, particularly the students. They are one, prediction and prevention, particularly on endometriosis. He used to say that strike at the root and catch the people early and he always is to say that publish your work or you will perish. And with his inspiration, this endometriosis society was the first society to be started in the year 2023. So I remember as the first society, the first national society, rather, I should say, not only in India, but also in the Southeast Asia. our mission and vision. Now, I always say that we are endometriosis fighters, and we dare not saying that we will lead to an endometriosis-free world. We also say that we thrive to find out and share the more facts at its molecular level so that improvements can be made in diagnosis and new targeted medicines with minimal side effects can be developed. Yes, the most important area we aware whom the people and general practitioners on this global epidemic, the endometriosis. I now prefer this term endoadenocomplex for its earliest suspicion. These two words are very important to me. And we dream. What do we dream? To see endometriosis predicted at its preclinical level. It is being treated near permanently. It is not possible to treat permanently, but near permanently we can treat it, yet without jeopardizing a woman's reproductive failure and stopped to make a woman's life miserable. Coming down to the basic structure, our secretariat is being held in Kolkata and our life members are nearly 900 plus. I try to follow the Foxy norms, and accordingly, I just made this whole country, divided the whole country rather in 5 zones, and we have deputed 5 zonal coordinators. And after that, we made the different chapters. As you can see over here, the Varanasi chapter, which is being running by Dr. Sangita Rai and Dr. Sudha Singh, Muzaffarpur by Dr. Prachi Singh, Darbhanga by experienced Dr. Bharat Prasad, Jaipur part recently being inaugurated by Dr. Anju Soni, and I have got quite a few names of the chapters which are upcoming like Chennai, Hyderabad, Faridabad, etc. Our journey since inception, yes, it was a very tough journey because during that time in 2003, nobody used to know about endometriosis and it was restricted in 8 to 10 pages in a textbook, and everybody used to laugh at us that what the hell you're doing? You're doing one organization on a disease. Oh, how funny you are. Anyway, the journey started in 2003, and 2003 to 2010. We held various scientific programs and live workshops, mostly in Kolkata. And my hats off to our then Secretary General and past President, present President rather, Mr. PDM Sir. From 2010 to 2020, more and more stress were given on public awareness. The first and second international conference were held in 2015 and 2019 at Kolkata and Jaipur respectively. We held one very good Dream City meet in Durgapur, West Bengal. And then 2001 to 2025, we tried to involve world-class luminaries as advisors of ESI, and so far I recall, I could made it in 33 countries, and many people are contacting us to join our society in the advisory board. We are trying to do the same in near future. The most first successful and the first endometricon was held in 2023 at Varanasi. Yes, this was organized by Dr. Sangitara and Dr. Sudha Singh 24, and there is a miswriting over here that was held in 2024. And we could hold the third and fourth international conferences on 2023, and Dr. Ramania said in 2025 recently in Kolkata. In spite of all odds and restrictions, both of them were huge success. Now, we are making publications in our quarterly journals in the form of endometriosis updates, and I express my heartfelt thanks to Dr. Ruma Sinha and Dr. T. Ramadevi to taking to take initiative for this entire program for these journals. And these have become very popular not only in India but also abroad. And a lot of requests are coming to me to send the link or share the e-copy to our who want to know about our work. I personally give special emphasis on 4 areas. The first one is the awareness and screening. I used to do awareness for a long time, but I give a lot of stress on screening at the same time, particularly on adolescent girls at the school level. Secondly, branding of Indian session. Yes, that was one of the missions, and it was possible to do it, or rather have to ESI sessions in Asian Conference of Endometriosis on 2 consecutive occasions at Manila, Philippines, and at Bali, Indonesia. Then we could become one integral part of ACUD conference, that is Society of Endometriosis and Uterine Disorders. For last 5 to 6 years, I must give a lot of thanks to Dr. Parul Kotlawala, who is taking all the initiative for the same. Now, of late, we are arranging trainings in world-class endometriosis labs in US and Canada, and I'm trying to involve and get people from our society so that they can have some training in these labs in those countries. Then research work. Yes, as Dr. Ramani was telling, this LME project, it has just started. It will run from 2026 to 2029. And you can see I am here as principal investigator along with Dr. Ramani Devi is here as co-investigator, and other members of ESI are here. And we are doing the same under the NHS Foundation Trust UK, Hampshire and Isle Healthcare. And the theme is exploration of mental and physical impact among endometriosis women. This is the work package 2A. But before that, we did quite a few work packages on Mary and Plato projects, and it is being continued with the Asian members of Darbhanga especially, and Varanasi and Muzaffarpur, and they are working as co-investigators of Mary and Plato projects. Coming down to the academic activities, it was a dream of mine that in various international journal publication from Endometriosis Society will be there, and of late we could do it. The Mary project and the part of the Mary project have been published in 2024 and 2025, where I was the principal investigator and co-author, and then our Dr. Malaraj, his publication is there also on hysteroscopy, and then on Plato project, where I myself was investigator and principal investigator and co-author, and that is going to be published in Lancet. It is in press, and another work is going on. A part of it will be published on anti-angiogenic drugs, where our collaborators are from Ohio State University, United States, and first part is in the press. Now, I am very glad to be a part of Foxy ICOG 3D teaching series in endometriosis, where many of our members had been the faculty, and this program lasted for 3 days from 24 to 26 of February this year. And not only that, 4 to 5 members, maybe more than that, have been invited as faculty in the SEUT conference 2026 at Frankfurt. I wholeheartedly request all Foxians and non-Foxians, but a member of our fraternity who are not yet a member, to join. Please join Endometriosis Society India as a life member. Why? Just to promote the fight against endometriosis, and side by side to promote endometriosis awareness, not only in the month of March, but also every day in the whole year. Lastly, it is my privilege to acknowledge and extend my heartfelt thanks to Alcare and Alembic, and I declare today that all gynecologists or members of our fraternity will, not only in India but across the globe, would be invited to join this webinar for next 6 months, and a course completion certificate would be sent to all of them. We're trying to have credit points for all of them. Dr. Ramani Devi has already highlighted this area, and now it is the time, and I'm rather privileged to offer a special thanks to whom? Our Foxy President, my beloved Dr. Bhaskar Pal, and ICG Chair, Dr. Sheila Mane. I wish this webinar series would not only be a great success, but also a grand success. Thank you very much, Dr. Ramani Devi, and it's over to you.
Ma'am, you're on mute. Dr. Ramani Devi, you're on mute.
Thank you, Dr. Pradeep sir, for your intro about the Endometriosis Society India. I wish all the participants of this webinar should become the life members and then get involved in creating awareness and gaining knowledge. I think next should be Dr. Bhaskar Pal. I don't know whether he had asked me to send the link. I've sent it, but I think he's yet to join. And the next person is Dr. Sheila Mane. I don't think she has also joined. Sheila Madam, have you joined? Huh? Okay. Then I welcome Dr. Sheila has already joined. She is the chair of ICOG 2026 and member health system strengthening the committees of FIGO, Vice President Foxy in 2014, Chairperson Safe Motherhood Committee, President BSOG, President BMS Bangalore, and National Facilitator in Adult Health in WHO. And then she has so many other credits, and she is the president of ISOPAR Bangalore Society and reviewer for Jogi, faculty for FIGO PPH stimulation workshop. And we all know Dr. Sheila Mane as the PPH lady of India. She's on the line. Madam? Okay. Yeah, have you joined our session? Okay. She is in a different program now. So when she joins, we will have her words of wisdom. Okay, I think with this, we can go ahead with requesting the chairperson to begin the scientific session. Pallavi, can you focus the CV of Dr. Uma Velmurugan? Yeah. Dr. Uma Velmurugan is an fellow of Royal College of OBGYN. She did her fellowship in reproductive medicine in Birmingham. Currently, the managing director and chief consultant at Venus Fertility Center, as well as Apollo Specialty Hospital. She was the secretary for TRIOX, that is Trichy OBGYN Society, and her Rockford annual fertility CME in Trichy is it has been appreciated by many, and she has been the first founder president of Trichy chapter of TAPISAR, and her special achievements are Young Talent Award by ISAR in 2022, Rising Star ISAR Award by TAPISAR 2023. Over to Dr. Uma Velmurugan. Uma, Dr. Hepzibah will be joining only late, so you can introduce Dr. Ashika and then start the academic program.
Sure, madam. Thank you for those kind words of introduction. We move on to the scientific session now. I think our first speaker will be Ashika. Thank you. Dr. Ashika is a consultant obstetrician and fertility specialist, Shenbagam Nursing Home, Pattukottai, and Janani Fertility Center, Pattukottai. She has had her UG from Tanjavur Medical College and post-graduation from Raja Muttaya Medical College, and she was the university topper in her post-graduation, had a diploma in IVF and reproductive medicine, Kiel, Germany, and she has done the ICOG course in reproductive medicine and a diploma in gynecological ultrasound from Kiel, Germany as well. She's a life member of FOXY, IFS, PCO Society, ISAR, and been a faculty in various state and national conferences and contributed to many chapters and books. Her field of interest is reproductive medicine and high-risk obstetrics. Over to you, Ashika, for your lovely presentation of the day. We welcome you to this meeting.
Thank you, ma'am, for the kind words of introduction. Am I audible, ma'am?
Yes, you are.
Audible.
Can I share my screen now?
Please.
Pallavi, stop sharing. Yeah.
Good evening.
Yes,
sir.
Visible.
Yeah. Good evening, everyone. I first of all thank Dr. Ramni ma'am for this wonderful course and purely dedicated to endometriosis. And thank you, ma'am, for entrusting me with this topic. So today I'm going to discuss on etiopathogenesis of endometriosis. So the contents of the talk is going to be introduction, prevalence, why understanding of etiopathogenesis is important, all the theories explaining the origin of endometriosis, role of genetics and epigenetics, and conclusion. By definition, the presence of normal endometrial tissue abnormally implanted in locations other than the uterine cavity is endometriosis, and these implants grow and invade tissue in their vicinity, causing inflammatory reactions. So, endometriosis, as we all know, is one of the most enigmatic diseases in gynecology. And despite more than a century of research, its exact etiopathogenesis continues to challenge clinicians and scientists worldwide. Why this etiopathogenesis is of importance? It explains the heterogeneous clinical presentation of the disease. It helps identify the risk factors and early disease mechanisms. It also forms the basis for targeted and personalized therapies. It improves early diagnosis and prevention strategies. And it also guides future research and therapeutic innovations. So endometriosis, as we all know, is a highly prevalent condition. Younger age at onset predicts more severe disease. So we can see that 25 to 40% of the infertile women, 75% of the women with chronic pelvic pain, and 40 to 60% of women with dysmenorrhea are all suffering from endometriosis. And as per recent estimates, about 196 million women suffer from endometriosis globally, and of these, 50 million women belong to India alone. Endometriosis can affect various sites like the ovaries, the peritoneum, the rectovaginal septum, and even the bladder, ureters, etc. And the most common symptoms of endometriosis are the 7Ds: dysmenorrhea, dyspareunia, dysuria, dyschezia, DUB, diffuse abdominal pain, and difficulty in conception. Several theories have been proposed for explaining the pathogenesis of endometriosis. But what we have to know that there is no single theory explaining all the cases. So before going to the theories, let us know few things about the epidemiological factors and the basic molecular alterations happening in endometriosis. So the epidemiological factors includes decreased parity, early age at menarche, shorter menstrual cycles, and increased duration of flow. Even there is history of family history, decreased BMI, and personal habits like increased alcohol drinking, inconsistent diet, smoking, but smoking has no effect. Regular exercise can prevent endometriosis. When there is a sedentary lifestyle, it increases endometriosis. So the basic thing that which is important to understand is the molecular alterations. So what happens here is the altered steroid biosynthesis and receptor response. There is increased estrogen receptor beta expression, there is increased aromatase expression, and there is disturbances in the progesterone signal intermediates, and there is deficiency of 17 beta hydroxysteroid dehydrogenase. So the increased invasiveness and vascularization is due to upregulated MMP expression, increased VEGF, overactive AKT, and recruitment of Tie2 expressing macrophages. The inflammatory response is due to RANTES, MCP1, interleukin 8, the chemokines, they increase in number, and the recruitment of alternatively activated macrophages. Increased peritoneal interleukin 6, TNF, engagement of nuclear factor kappa, and accumulation of iron and reactive oxygen species. So let us start with the theories contributing to endometriosis. First is the tissue injury and repair mechanism. So when there is a continuous micro injury happening to the endometrium, especially the endomyometrial junction or in the junctional zone, what happens is that as a part of repair mechanism, the estrogen and aromatase increase, and this estrogen causes proliferation, survival, and the infiltrative growth of the ectopic endometrium. As this injury and repair mechanism becomes a vicious cycle, the endometriotic cells can displace themselves and get attached to other parts of the uterus or outside the uterus. So this is the tissue injury and repair mechanism. Next is the most well-known theory, the retrograde spill theory proposed by Sampson in 1927. He postulated that the menstrual blood flow backwards through the fallopian tubes, allowing the endometrial cells to implant on peritoneal surfaces. These endometrial cells in this reflex menstrual blood then implant on the peritoneal surface and develop into endometriotic lesions. So we can see in this picture that the menstrual shedding blood goes back into the fallopian tube and gets itself implanted outside the uterus, and the series of inflammatory changes happens and they become endometriotic lesions. But the points not favoring this retrograde menstruations is that while retrograde menstruation is common in most menstruating women, only a subset develop endometriosis, suggesting additional contributing factors. It cannot explain deep infiltrating endometriosis or endometriosis in Rokitansky syndrome, where the individual will not be having a functional endometrium. It cannot explain endometriosis in distant sites like diaphragm, lymph nodes, or endometriosis in males. Next to the coelomic metaplasia theory, where this was proposed by Mayer in 1919, they have suggested that the coelomic wall derivatives, which are nothing but the peritoneum, endometrium, etc., have the capacity to undergo metaplastic changes and change themselves into endometriotic cells. So this theory suggests that the peritoneal cells, under certain conditions, can transform into endometrial-like cells. So this can be caused by endocrine disrupting chemicals. And also this theory, one good thing about this theory is that it is supported by the cases of endometriosis in individuals without a functioning endometrium like MRKH syndrome. Next comes inflammation and endometriosis. So once the endometriotic cells implant themselves outside the uterus, there is a series of inflammatory and immunological reactions that takes place. And these immune cells like macrophages, natural killer cells, neutrophils, lymphocytes, etc. are produced in large quantities, and these cells in turn release cytokines like VEGF, TNF alpha, interleukin 1, interleukin 6, adhesion molecules, prostaglandins, etc., which result in proliferation of the lesion, vascularization of the endometriotic lesion, and its survival. Coming to hematogenous and lymphovascular spread, this theory suggests that endometrial cells have the capacity to travel through the blood vessels and lymphatics to distant sites, and this explains the reason behind extrapelvic endometriosis. Coming to stem cell theory, which is one of the newer theories, this theory states that some stem cells from the uterine endometrium or the bone marrow have the capacity to change into any other type of daughter cells. So these progenitor cells may differentiate into endometriotic lesions, and this suggests systemic involvement beyond local implantation. So what happens here is the epithelial stems or the progenitor cells may enter the circulation, home to endometrium during the regeneration of the proliferative phase, and go astray ectopically to form deep infiltrating endometriosis. Another interesting theory is the theory of fetal origin, where this theory suggests there are endometriosis cells present even at fetal life. This theory was supported by the following evidences, which states the endometriosis of adolescents preserve some distinctive characteristics of fetal endometriosis cells and were ontogenic resistance to progesterone. There is recently another study through a careful autopsy analysis. One research group has highlighted the presence of endometriotic structures in 10% of female fetuses, and also the glandular and stromal tissues that were found to be receptor positive for estrogen through immunohistochemistry. So these scientific evidences clearly support the fetal origin theory. There is also an interesting study which states the presence of neonatal uterine bleeding may represent a warning sign of the future development of endometriosis and increase the awareness of devastating disease in the young women. So this also follows the same mechanism like retrograde menstruation. And once these endometriotic cells get implanted, and when the female attains puberty, upon the action of estrogens, these lesions grow and form endometriotic lesions. Embryonic rest theory suggests that embryonic tissue arises from embryonic remnants of Mullerian duct. So the persistence of these Mullerian cell rests, they remain in the pelvic structures like peritoneum, rectovaginal septum, ovary, bladder, etc. And on stimulation by estrogen at puberty, they differentiate into endometriotic cells. Immunological theory is yet another important theory where normally for a female, if the endometriotic cells gets implanted outside the uterus, they have to be recognized as a foreign body, and upon the action of natural killer cells and macrophages, they have to be phagocytized and destroyed. But what happens in endometriosis is that these females have an altered immune reaction, and by that the natural killer cells activity is decreased, and the macrophages here are abnormal, and they release a lot of cytokines like interleukin 1, TNF alpha, interleukin 8, etc., VEGF, etc., which causes immune escape, invasion, angiogenesis, and growth of the endometriotic lesions. Angiogenesis and neurogenesis is also another good theory where it denotes endometriotic lesions require new blood vessel formation, angiogenesis, for sustenance. The pro-inflammatory cytokines, mainly the interleukin 6 and 8, when they are found at higher concentration, help in angiogenesis. So increased expression of vascular endothelial growth factor VEGF promotes vascularization, and neurogenesis also leads to heightened nerve fiber density, contributing to the chronic pelvic pain. So we can see that both neurogenesis and angiogenesis takes place in ectopic endometrial implants, and they release neurotropic and angiogenic factors. The neurotropic factors like nerve growth factor and brain-derived neurotropic factors all recruit sensory nerve fibers, and VEGF, PDGF, etc. causes proliferation of blood vessels. The neuroangiogenesis together causes inflammation, and mainly the neuroinflammation causes release of substances like substance P, CGRP, and cytokines, which are main substances of the pain transmission pathway. And this is the common cause for chronic pelvic pain and dysmenorrhea in endometriosis. Gut dysbiosis is also related to endometriosis. So generally, our gut microbiota is responsible for metabolism, hormonal balance, and immunity. So when this gut microbiota is disrupted, there are chances of developing endometriosis. So in gut microbiota, there are certain bacteria which produce beta glucuronidase, which is involved in estrogen metabolism. So when this beta glucuronidase secreting bacteria or this glucuronidase enzyme is disrupted, or its function is being altered due to external factors like toxins or improper dietary factors, what happens is that the metabolism of estrogen is deranged, and there is a lot of estrogen absorption into the blood vessels. So when there is hyperestrogenic state, there is more risk for developing endometriosis. Etiopathogenesis of hormonal reasons. So we all basically know that endometriosis is a state where progesterone resistance and estrogen is dominant. So this dominant estrogen and aromatase action causes generally cell proliferation but decreases its apoptosis. It increases inflammation, angiogenesis, and neurogenesis. So endometriosis is an estrogen dependent condition, and high levels of estrogen promote growth and survival of ectopic endometrial tissue. Progesterone resistance leads to inadequate suppression of this lesion's growth, and the inflammatory mediators such as prostaglandins and cytokines exacerbate the symptoms like pain and inflammation. Coming to genetics of endometriosis, there is 6.9-fold increase in the incidence of endometriosis among family members. Familial clustering and twin studies show heritable risk. So there was an interesting study, global study, that showed the experience of endometriosis is rooted in genetics. And this study involved analysis of DNA from more than 60,000 women. It involved around 25 academic and industry groups contributing to the data. And they have given an overview of genetic polymorphisms related to the development of endometriosis. This study has great benefit for understanding the disease mechanism, novel diagnostic approaches, and development of targeted therapies. So, though it gives more opportunities, there are certain challenges like elusive understanding of endometrial pathogenesis, lack of non-invasive diagnostic methods, ethical considerations, etc., which causes challenges for the study. Finally, coming to epigenetics in endometriosis, epigenetics is nothing but the alteration in the gene expression without changing the gene sequence. So epigenetics can happen in DNA methylation, histone modification, miRNA regulation, etc. And when there is gene expression changes, it can lead to inflammation, proliferation, and angiogenesis, etc. So how this epigenetic changes occur? It can be due to endocrine disrupting factors like PCBs, dioxins, BPA. So these endocrine disrupting factors cause hormonal imbalance, inflammation, which is a key factor for development of endometriosis, and cell growth and survival, which is the hallmark of endometriosis. These epigenetic changes can also be due to lifestyle factors, which includes diet factors like increase in red meat, trans fats, and low omega fatty acids, sedentary lifestyle like decreased physical activity, and chronic stress, which can all lead to systemic inflammation, immune dysregulation, estrogen dominance, and growth of endometriotic lesions. So to conclude, we have seen all the theories, but remember that endometriosis is a multifactorial systemic disease, not merely a consequence of retrograde menstruation. It results from a complex interaction between genetic susceptibility, hormonal imbalance, immune dysfunction, neuroangiogenesis, and environmental influences. So understanding these mechanisms enables earlier diagnosis, personalized management, and it is high time that we move from symptomatic treatment toward individualized mechanism-based management strategies. Thank you for the opportunity. Thank you for your patient listening.
Uma, are you there? Now, see let the MCQs be in the end. Now,
Okay.
Dr. Bhaskar Pal has joined. So I welcome Dr. Bhaskar Pal to say a few words. And
Good afternoon, everyone. I actually congratulate the Endometriosis Society of India under the leadership of my two seniors from Kolkata, Dr. Pramathesh Dashmahapatra and Dr. Pradeep Mishra. And I also congratulate Dr. Ramani Devi, who's been working in endometriosis area for a long time, and Dr. Hebziba and the entire team. March is the Endometriosis Awareness Month, and we have a lot to do as far as awareness is concerned, because we know that endometriosis even now gets diagnosed really late. People have a tendency to normalize symptoms. And there are studies which shown, especially in younger women, sometimes it takes even up to 10 years for endometriosis to be diagnosed by the time they have visited multiple doctors. And that is why it is important to raise awareness about endometriosis. Secondly, irrespective of whatever we do, the outcome of endometriosis is often unsatisfactory. But fortunately, a lot of research is going on and new data, new evidence is coming regularly. So this is a very timely, comprehensive course on endometriosis, which will go a long way in helping women with endometriosis by educating healthcare providers as well as raising awareness. Thank you very much for having me. Thank you. Over to you, ma'am.
Thank you so much, sir. Thank you. In spite of all your busy schedule, I thank you so much for coming and addressing the webinar series. Thank you so much.
My pleasure. Thank you.
Thank you. So, Pallavi, I think the end we will have the MCQs. So next I request, Uma is there or not?
Yeah, I'm here, ma'am.
Yeah. Next person.
Next is, the next speaker is going to be
Dr. Harshini. Harshini will be the next speaker.
Next speaker is Dr. Harshini, who is my colleague in Apollo Hospitals, Trichy. Welcome, Harshini, and her areas. So she's a young, enthusiastic, bubbling gynecologist who is always smiling whenever I see her. Her areas of interest are advanced laparoscopic surgery, robotic gynae procedures, and fertility treatment. She is very much into academics. She has presented and published multiple papers at national and state conferences. I've heard her speak in quite a few conferences, and her professional membership, she is a member of IMA, IFS, ISA, TRIOGS, IAGE, I think what the world, and Endometriosis Society as well. And so I hope you're a life member, Harshini. And the stage is yours. We'd love to hear from you about endometriosis. I think it's a staging, isn't it? What are you going
Classification.
to classification? Yeah. Over to you, Harshini.
Thank you, ma'am, for your kind introduction.
Harshini also won the Best Paper Award in the recent International Conference of Endometriosis in 2025 at Kolkata.
Thank you, ma'am, for your kind introduction. Thank you, Ramani, ma'am, for this great opportunity. I would love to share my screen.
Make it full screen, ma'am.
Yes, ma'am. So good evening, respected seniors, chairpersons, and colleagues. Today, I'll be discussing about the classification of endometriosis and giving a comprehensive overview of the current system which are in use. As we know, endometriosis is a heterogeneous disease with a wide variability in its presentation. Because of this diversity, no single classification system can capture all aspects of this disease. In this presentation, I will discuss about the evolution of endometriosis classification, highlight the major systems we use today, outline the strengths and limitations, and discuss the possible future directions. So, endometriosis is a chronic estrogen-dependent inflammatory disorder characterized by presence of endometrial-like tissue outside the uterine cavity. It affects 6 to 10% of reproductive age women. and up to 30 to 50% of women presenting with infertility. Common sites includes ovaries, pelvic peritoneum, uterosacral ligaments, rectovaginal septum, bladder, and bowel. And rare extrapelvic sites such as diaphragm, lungs, and even the spleen have also been reported. Why do we need classification? Because endometriosis varies widely in the extent, symptoms, and impact on fertility. Having a structured classification system becomes important. An ideal system should be describing the extent of the disease. It should predict the severity of pain, predict the fertility outcome, guide the surgical management, and also allows the standardized reporting in research. Initially, evolution of endometriosis classification. Initially, classifications were simple description of appearance and location. That is the early descriptive and surgical classification. Over time, more structured systems emerged, like Acosta classification in 1973, American Fertility Society AFS classification in 1979, Revised American Fertility Society RAFS classification in 1985, Revised American Society for Reproductive Medicine RASRM classification 1996, NCN classification 2003, which has been revised in 2012 and 21, Endometriosis Fertility Index 2010 proposed by Adamson and Pasta, American Association of Gynecological Laparoscopists AAGL in 2021, Numerical Multi-Scoring System of Endometriosis NMSE, ESHRE, and SG and W World Endometriosis Society. These are phenotype-based approaches. So, before the 1970s, the classification broadly described superficial peritoneal disease, ovarian disease, and deep infiltrating disease, like the early descriptive and surgical classification, which was pre-1970s. They just classified into superficial peritoneal, ovarian, and deep infiltrative. And they, because of that, they have poor reproducibility, clinical correlation, and no standardized scoring. The Acosta classification in 1973 was one of the earliest structured attempts, but showed poor correlation with symptoms and though it was based on the site of the limitations are poor correlations with pain and fertility. American Fertility Society classification 1979. It is based on the size and depth of the endometriotic implants, adhesions, and involvement of ovaries, tubes, and cul-de-sacs. It has 4 stages based on the lesion characteristics and adhesions. Stage 1, which is minimal, stage 2 is mild, stage 3 moderate, and stage 4 is severe. Limitations are that they did not correlate with pain or fertility outcomes. This was improved as RAFS in 1985, providing a point-based scoring system. Still, major limitations remains the same, poor correlation with symptoms and fertility. So the revised ASRM, Revised American Society for Reproductive Medicine classification 1996. The RSRM classification remained the most widely used system even today. It uses operative findings to classify disease into 4 stages from minimal to severe. Stage 1 has superficial implants, which includes the superficial peritoneal implants or minor ovarian endometriomas. Stage 2, 16 to 15 points, featuring deeper implants on the peritoneum, ovaries, often with adhesions. Stage 3, 16 to 40, involves many deep implants, ovarian endometriomas, and characterized by large endometriomas and significant adhesions, also altering the anatomy. However, the system correlates poorly with pain. That is, the stage 1 minimal might have severe pain and stage 4 might have can be asymptomatic as well. So this system correlates poorly with pain, does not adequately describe the deep infiltrating endometriosis, and often fails to predict the fertility outcome. So this is the diagram. The diagram visually demonstrates how RSRM stages increases in terms of the lesion load, adhesions, severity, and ovarian involvement. The key point is that the anatomical stage does not correlate with the symptom severity, like I already stated. Like the stage 1 minimal has superficial deposits and some left ovary superficial endometrioma, which is less than 1 centimeter. Stage 2 having deep endometriosis, which is greater than 3 centimeter, but right ovary having superficial endometriosis less than 1 centimeter, and left side also less than 1 centimeter, having points which is lesser than 4, having a moderate and severe, where we can see adhesions, and in stage 4 severe, where there is distorted anatomy because of the endometrioma as well as the adhesions. Enzian classification 2003, which is also revised in 2012 and 21. The Enzian system was developed specifically to address the poor description of deep infiltrating endometrioma disease, which is lacking in RSRM. The most recent revised classification, Enzian classification, is comprehensive. It includes the superficial disease, ovarian disease, tubo-ovarian adhesions, and also the deep lesions. It allows better preoperative planning, works well with imaging modalities. So like this, this is the picture where the peritoneum, where the implants are on the peritoneum. So and ovary, which is O, and T is the tubo-ovarian condition. In deep endometriosis, it is A, rectovaginal space, vagina, rectocervical area. B, uterosacral ligaments and the pelvic side wall. C, rectum. F, far, that is FA is adenomyosis. FB, bladder. FI, if the implants is in the intestinum. FU, ureter. F, you can also specify the location which is in the diaphragm, lung, or any nerve involvement. So here the lesion size, that is P1 in P and O, that is if it is less than 3 centimeter, we grade it as P1 or O1. If it is 3 to 7 centimeter, we can grade it as P2 or O2, which is 3 to 7 centimeter, and greater than 7 centimeter is P3 or O3. And in tubo-ovarian condition, we again label it as T1, which is in the pelvic side wall, T2 pelvic side wall as well as the uterus, and T3 is pelvic side wall, uterus, bowel, uterosacral ligaments. In deep endometriosis, if the lesion is less than 1 centimeter, we grade it as A1, B1 or C1. And if the lesion is 1 to 3 centimeter, we grade it as A2, B2 or C2. And if the lesion is greater than 3 centimeter, we label it as greater than 3 centimeter. So each area is graded by the lesion size, making the system highly descriptive and clinically useful. Endometriosis Fertility Index, proposed by Adamson and Pasta in 2010. It predicts the spontaneous pregnancy after endometriosis surgery. It combines historical factors like age and duration of infertility with surgical assessment of tubal and ovarian function. The score ranges from 0 to 10. Higher score predicts better natural fertility. However, EFI excludes factors like AMH and semen parameters, does not correlate with pain. So this is the diagrammatic explanation. The graph shows how pregnancy probability increases with higher EFI scores. Patients with scores 7 to 10 have the best chances for spontaneous conception. Scores 4 to 6 may require assistance, and score less than 3 often requires IVF. EFI is helpful but must be interpreted with AMH, semen analysis, and full infertility evaluation. American Association of Gynecological Laparoscopists, AAGL, it was introduced in staging system in 2021. This classification shifts focus from anatomy to surgical complexity. It assigns scores based on the lesion type, depth, and adhesion, then categorizes cases into 4 levels of surgical difficulty. That is stage 1, less than 8 points, minimal disease; stage 2, 9 mild disease; stage 3, greater than 16 to 21 points, and if potential benefit is it's better. So this is the AAGL diagrammatic representation. This diagram shows AAGL assigns scores and divides disease into 4 complexity. That is, if superficial, vagina, left ovary, cul-de-sac, rectum, and small bowel, all these things. If the involvement is less than 3 centimeter, then the score is graded as 2, and if the involvement is greater than 3 centimeter, then the score is greater than 4. Then for the left ureter, if the extrinsic, then the score is 6, intrinsic, the score is 8, and hydroureter, then it is 9. If for the fallopian tube, slight serocell involvement, it is 2, moderately immobility 4, severe immobility 6, complete obstruction is 7. And cul-de-sac obstruction, it is partial, it is 6, and if it is complete, it is 9. So numerical multi-scoring system of endometriosis and ESHRE, SG and WAS consensus. The NMSE uses ultrasound and pelvic exam findings to generate a numerical E-score based on factors like cyst size, adhesions, pain, and uterine findings. It predicts both surgical complexity and fertility potential. International societies like ESHRE, World Endometriosis Society consensus. It is a phenotype-based classification integrating lesion location, depth, type, symptom correlation, imaging, and surgical findings. So this slide basically summarizes how classification has evolved from a simple descriptive system to structured staging like AFS, RSRM, and to specialized system addressing deep disease NCN and EFI, and also surgical complexity AAGL. Newer system aim to integrate all relevant components into one model. So the conclusion, multiple classification system exists for endometriosis. In real clinical practice, there is no single system which is adequate. RSRM remains most widely used. NCN describes deep infiltrating disease. EFI predicts the fertility. AAGL assists the surgical complexity. Often a combination is required for comprehensive evaluation. Limitations. Despite multiple systems, several limitations persist. Poor correlation with pain, limited prediction of fertility, inadequate description of the deep disease in older systems, complexity of newer system which limits the use. The classification still does not fully reflect the complexity of endometriosis. Future directions, AI in endometriosis classification. Artificial intelligence may transform endometriosis classification by enabling automated detection of lesion on imaging like MRI and ultrasound, prediction of surgical complexity using imaging data, integration of clinical imaging and surgical findings, creating a 3D pelvic mapping of disease. This can improve diagnosis, disease mapping, and also help in personalized treatment. So to summarize, endometriosis is a diverse and complex disease. Multiple classification systems exist, each serving a different purpose. A unified, comprehensive system that integrates anatomy, symptoms, fertility, imaging, and surgical findings is needed, and AI may be helpful in achieving this in the future. Thank you.
That was a very excellent presentation, Dr. Harshni. You went through the timeline starting from the 70s till 2025, and currently I think depends upon like if the endometriosis surgery is done by a fertility specialist, then they focus more on the fertility index, isn't it? And depends on what are the needs of the patient. And commonly, I think, as you said, it's the revised ASRM classification we are still using, but slowly moving towards the enzyme. A lot of us have started using this, and maybe the fertility EFI as well, the fertility index. So when AI comes, AI is coming a big way in all the fields, isn't it? When AI comes, it'll be much easier for us and kind of will give a comprehensive outlook about the disease so that we can plan and treat the patient as a wholesome, not a symptomatic treatment or not image related treatment. Okay, thank you very much for that lovely presentation. Madam Ramni, madam, you want to add something?
I think she has covered almost everything, but as a fertility consultant or an endoscopic surgeon, it is our duty to mark the endometriosis fertility index in each of the surgical reports. So that is one way of helping the patients as well as ourselves. What should be the modality of treatment? She has clearly made out the EFI score. When it is going to be higher, the results of spontaneous consumption is going to be better within 2 to 3 years post-surgically. And again, if the EFI score is between 4, 5, 6, and 7, then in younger patients, depending upon the tubal factor and other AMH level, the spontaneous consumption is still feasible. But only thing is, we cannot wait for a longer time. But at the same time, if the EFI score is less than 3, then it means the patient has to go straight away for ART. But the only disadvantage of endometriosis fertility index is that they have not included the male factor as well as the AMH level. So that is one drawback of this particular endometriosis fertility index. Probably in future we can include that also. And NCN system, you have clearly mentioned that it is going to be the deep infiltrative endometriosis. We can make a mark extra pelvic. All those things are again comfortable with the NCN scoring. And AAGL scoring is ideal for planning for surgery. So all these things she has brought out in her talk. Thank you, Harshini. So next, Dr. Pallavi, you can show Dr. Hepzibah's CV.
Yes, ma'am.
Yeah. I will share her presentation because she's traveling. I will share her presentation. She can talk. I am proud to say me and Uma Velmurugan, both of us are students of Professor Hepzibah.
It's indeed a great privilege for me to introduce my mentor, teacher, who still guides me in times of need, Professor Hepzibah Tribamani. She's been with me in RSRM in my UG days as well as my postgraduate days. Madam has a lot of laurels to her. We all fondly remember her with her. I was just telling my staff today, like Madam is presenting, and they remember her with her rose in the side matching to her saris. That's how my staff all remember her. They've seen her quite a few times in Trichy. Madam has been the past president of Obstetrics and Gynae Society of Southern India and past president of Chennai Menopause Society, treasurer of IMS, and you can just keep on going. And I would say like two persons who I would really link about academics is one is the first person who I met was Professor Hepzibah. She's been doing a lot of research since my undergraduate days, that is in 90s. And the other person who I'd say involved more in academics is Dr. Ramani Devi Madam, who I always call her as an encyclopedia of endometriosis. Any doubts, I always reach out to call her. And it's really an indeed pleasure to be with both of them today. Madam Hepzibah, Madam, the stage is yours, and we are eagerly waiting to listen to you. Madam.
Ma'am, you are on mute. Ma'am, you are on mute.
Yeah. Thank you, Dr. Ramani Devi and Dr. Uma, for the kind invitation and the kind introduction. It's very nice to be with you all. Sorry, as I'm traveling, I couldn't present it properly, and the sequence also has changed. Can I have the first slide?
Pallavi, please stop sharing. Yes, I will share Madam's screen. Yeah. Okay, can you see the screen, Madam?
Yes.
Hepzibah, Madam,
Yeah.
Can you see?
The topic given.
Okay.
Yes. Can you hear me? Yeah.
Yes, Madam. You
The
are quite
topic given
audible.
to me is epidemiology of endometriosis. Can I have the first slide?
Yes, the slide is on.
Next slide.
Yeah. This one.
Yeah. Just to recapitulate what is
Madam? Madam? Hepzibah, madam? We can't hear you. We can't hear you, madam.
Maybe she has got a poor connectivity.
Yeah. Okay, otherwise, I will go ahead. So, to learn something about the epidemiology, which means we should identify what is the cause of the disease and the neighborhood, the prevalence. Madam? Yeah, prevalence of the disease, that is in which city, state, country, and global spread.
Yes.
Okay, you go ahead, madam. Health impact of the disease and what is the frequency or the pattern with which it is prevalent in that area and the socio-economic impact of the disease. Next slide, I will go. You start, madam.
Yeah.
Yes.
Next slide. Yes.
Go ahead, madam.
Yes. There are few questions in my mind.
I think she has network issues.
Yes. When the topic was given, few questions came to my mind. What is the historical perspective for endometriosis? What is the global and Indian pattern of endometriosis? What are the women to be suspected for endometriosis? What are the determinants of endometriosis? What are the health-related issues associated with endometriosis? What is its impact? What are the methods to prevent endometriosis? These are all the questions we have to think about it when we talk about epidemiology. Next slide. Next slide.
Change.
Yes.
Want me to go to the next slide?
Elusive symptoms. Next slide. Next slide.
That is, I have changed, madam. Now I am the historical figures.
Yes. The historical figures, I think you would have heard number of times Dr. Ramani Devi is talking about this. Queen Victoria was suffering from endometriosis and she was given an option, a painkiller and pregnancy. She took it the other way around. There she has a lot of children and she got away with the endometriosis. But this Monroe Muller, she died of, actually she took a lot of abuses and she couldn't tolerate the pain and she died. But today, women with endometriosis have lot of, though they have severe pain and they have more options. The modern advancement have not only made it possible to diagnose early, treat it, and it has got the stigma also has been removed. So that is the historical perspective. Next slide. Kind of change the, yes. Coming to the global pattern, 247 million women globally suffering from endometriosis. It takes nearly 10 years to diagnose. 30 to 50% of women with endometriosis have infertility. 1 in 10 women get affected during reproductive age group. An average 27, when the first is diagnosed endometriosis, they will be 27 years. 68% of the women with endometriosis were initially misdiagnosed with other condition. 82% of the women are at times unable to carry out day-to-day activities. This is the burden of the endometriosis. Next slide. So when we try to find out the prevalence, it is something like an onion model. See, when according to the health insurance, it is only 0.7. According to the diagnostic criteria, it is 1 to 2%. And based on clinical data, it is 7%. And when they are symptomatic, it is 13%. There is a limited literature on the prevalence of endometriosis, knowledge of which is essential for effective prevention. And though they have a lot of studies, there is large discrepancy in the prevalence number, leading to the disease being underestimated. Actually, the incidence is little high. Next slide. So coming to the global burden disease study, it's a database done for a 1990 to 2099. In this study, 204 countries among 21 regions, they have extracted detailed data. The incidence of disability adjusted life years of endometriosis from 2019 to 2019. And they have the trend, they have analyzed the trend in the incidence of disability adjusted life years of due to endometriosis at global, regional, and national levels in terms of age, social development index. Next slide. So it is considered as a disability disease. Next slide. So coming to the prevalence of endometriosis is peaked between 25 and 29, maintained a high global prevalence of endometriosis between the ages of 30 and 39, and dropped rapidly when the age was over 40 to 44, or between the ages 15 to 24, which may be related to the diagnosis of endometriosis, delay in diagnosis. However, it should be noted that there are also cases noted as approximately 2 to 5%. It also happens in adolescent age group and estimate range between 19 to 73. It can happen in extremes of age also. Next slide. Next slide. Yes. So this is another rating, age standardized prevalence rate. Globally, the endometriosis prevalence according to the age standardized prevalence rate is 20.47% to 18.32%. It is coming down. There is a trend in lowering down from 767.7 per 100,000 population to 610.57. There is a declining in trend according to the age standardized prevalence rate. There is a trend in global disease of the prevalence by region. There is a difference changes in the different regions. Okay, that is, there are 3 areas where there is a decline, mainly Central Latin America, South Asia, and high-income North America. But Eastern Europe, Western Europe, Central Europe showed least decline as per the age-related this thing. That is a variation in the distribution of the disease in different regions. Next slide. Next slide. It's moving.
There's a time lag.
Yes, yeah, time lag. The burden of when we, according to the socio-demographic index also, as the socio-demographic index is increased, the endometriosis in all regions worldwide show overall decreasing trend. Next slide. Takes longer time to change. Okay, this is again the daily adjusted life years according to the endometriosis. This is already, I think I mentioned, it is less in the Eastern Europe and the North Africa and Middle East. These regions with the lowest age standardized rate were high income, North America, East Asia, and Central Europe. Again, it is stressing that there is a variation in the region-wise also, the incidence. So, they have observed overall downward trend in endometriosis as per age related in all regions throughout the world and socio-demographic index as socio-demographic index is increased. Next slide. So there is a downward trend. This results indicate some success in the global efforts to combat endometriosis. The endometriosis awareness campaign might have had a huge impact on transforming the knowledge and the attitude of healthcare providers about the endometriosis and the importance of early diagnosis of the condition also. That's why it is showing a downward trend globally. Next slide. So, but though this is a big data, the GBD, the global burden of the disease, it lacks certain things, the study. The factors that impact endometriosis, including diet, environment, lifestyle, there are different in social security system, medical conditions, economy, and cultures in distinct regions and countries. So they have to do some more sub-analysis to find out the real incidence. Next slide. So Asians were reported to have higher prevalence of endometriosis than Caucasian, with higher frequency of moderate to severe endometriosis among Asians. A slight increased incidence of endometriosis was seen in Japanese and other Asian population, with a lower incidence among women of African descent compared to the Caucasian descent. These observations strongly suggest there is a necessity to examine variability in disease presentation in different populations. Next slide. So we're coming to the burden of endometriosis in India. 42 million women in India suffer from endometriosis. The time from the appearance of the first symptom of the disease to diagnose it takes nearly 8 to 10 years. Next slide. So there is a presentation also varies in India. When coming to this, 66% of the women suffering from infertility, either primary or secondary. History of miscarriage was reported in 33% women who had ever conceived. 77% women reported dysmenorrhea, 23% had dyspareunia, and 34% suffered from chronic pelvic pain. 14% were found to be suffering from dyschezia. So the endometriosis leads to substantial adverse health impacts ranging from reduced quality of life to fatigue, depression, and anxiety. The percentage also varies according to the this thing. Next slide. So there is a clinical phenotypes of endometriosis in India also varies. Ovarian endometrioma was the most common subtype of endometriosis in 58%, and deep infiltrating endometriosis was seen in 24%, superficial peritoneal endometriosis in 15% of Indian women, 45% of women in their study had single lesion type, 33% of women had 2 lesion types, 16% of women had all 3 lesion types. So, obese women appear to be more commonly diagnosed with superficial peritoneal lesion, whereas the highest proportion of deep infiltrating lesions were diagnosed above underweight women. So, these are all the things we have to keep it in mind when we treat a patient. So there is a lot of relationship with autoimmune conditions, various autoimmune conditions like rheumatoid arthritis, SLE, Sjogren's syndrome, celiac disease, all that can be associated. It's still under whether comorbids are an effect or the cause of the disease it's under exploration. Next slide. And variation in the distribution of phenotype in Indian studies, and another study is that women recruited in Eastern India had highest proportion of superficial peripheral lesion. Ovarian endometriosis was most commonly seen in Southern Indian population, 40%, and the North Indian population also ovarian endometriosis, 33%. The highest proportion of deep infiltrating lesion was observed in women recruited in the northern region of India, 83%, and there was an increased incidence of dye in women recruited from West Bengal and Assam region. These difference in incidence and the disease presentation in different regions of India could be due to ethnic difference and an environmental factor we should think about. So a lot of comorbid conditions are associated in an Indian study like type 2 diabetes, thyroid, rheumatoid arthritis, asthma, tuberculosis, and associated with endometrioid subtype of ovarian cancer. Thyroid dysfunction was the most commonly reported comorbid conditions. Next slide. Who are all the women to be suspect of endometriosis? It's our duty when somebody comes, we should suspect. It is found in, because infertility patient, we have to keep it in mind, 1 in 3. Women with unexplained infertility, adolescent girls with secondary dysmenorrhea, women with chronic pelvic pain, women with bleeding, 30% of them will have adenomyosis, family history of diagnosis, endometriosis in mother, sister, and grandmother. Endometriosis in 7% of women is associated with a genetic predisposition in the family. So what are the determinants of endometriosis? Early menarche has shown that early first cycle before the age of 11 is associated with the risk of endometriosis. Shorter than 27-day menstrual cycle, but it is unrelated to the number of bleeding days and the volume of menstruation. Clinical defects, including hymen and narrowing of the cervical canal. These are all the patients we have to think that they may go for endometriosis. And low BMI, small number of birth, age between 25 to 29, daily consumption of alcohol in the amount less is more often diagnosed in infertile women who are active smoker and whose body mass index is normal or below. Prevalence of minimal and mild endometriosis was inversely related to body mass index. Next slide. So I think this is dealt in depth by the etiology. She has done it beautifully. How does the endometriosis occur? Increased inflammatory mediators, autoimmune etiology, the gut microbe and microRNA, everything was dealt by the etiology person beautifully. Next slide. So diet, coming to the diet plays a very important role in preventing the development of endometriosis. The consumption of green vegetables, fresh fruits is considered most beneficial. They contain antioxidants which play an important role in proper functioning of immune system and the removal of free radicals. It is worth noting that fiber contained in the vegetables interacts in the control of intestinal bacterial flora and affects the hormonal balance. Next slide. So the red meat exerts an effect on the development of endometriosis compared to vegetables and fruits. It is characterized by high content of dioxin, hormone, and fat, increasing the concentration of estrogen. The study group consisted 81,000 women eating more than 2 servings per day. Red meat had 56% higher risk of endometriosis compared to those consuming 1 serving per week. Women who were classified in the category that consumed the most red meat were more likely to have endometriosis. No association with poultry, fish, shellfish, and egg consumption, and the risk of endometriosis was demonstrated. Next slide. So the exercise, the lifestyle factors, and the dietary pattern that influence endometriosis, the risk may relate to their ability to mitigate inflammation. Physical activity and omega-3 dietary fatty acids may reduce levels of tumor necrosis factor alpha, interleukin 6, and other inflammatory markers. While the association between physical activity and endometriosis is unclear, higher intake of long-chain omega-3 fatty acids has been associated with reduced endometriosis risk. So indirectly it acts. So endometriosis has got a significant negative effect on aspects of social, family, and sexual, educational, professional life. It directly affects the quality of life. Next slide. So the etiology of endometriosis is not understood well even after 100 years of research. Currently, there is no permanent cure for endometriosis. Next slide. So endometriosis still remains an enigmatic disorder without permanent cure with unique immunological alteration. We need to have high degree suspicion in certain clinical presentation. Next slide. So to conclude, it can be challenging to diagnose endometriosis early in everyday practice because of the severity of illness and the intensity of the symptoms often do not relate to one another. When we diagnose Thank you. Thank you.
Thank you.
Thank you for your patient sharing the presentation. Thank you. I'm very sorry I couldn't make a proper this thing. Thank you so much.
Thank you, madam, for that beautiful, colorful slides and your presentation. And as we know that endometriosis is an enigma. I remember reading it as a first line in Shah's textbook of gynecology. And though it still remains an enigma, we are able to penetrate into that enigma and then find out ways to help our patients either in the way of diagnosis or in treatment. Though we don't have a permanent cure, it still takes years to come. And I've heard, I think it's one of my teachers who said, like, if you can find a treatment for endometriosis, probably you'd be the next Nobel Prize winner. This is a common saying which I tell my patients as well. Whenever they ask me, like, what is a permanent solution? If I find it out, then I'll definitely let you know it's my answer. Thank you, madam, for that beautiful presentation.
Thank you.
Madam, thank you so much for your very nice presentation. I would like to add, for the benefit of the people who have registered here, endometriosis being a chronic inflammatory disease, apart from the autoimmune disorders, it has definitely got adverse pregnancy effects as well as long-standing metabolic problems in any woman. A patient with endometriosis, on a long run, she is at a risk of developing cardiovascular disease because the basic pathogenesis is atherosclerosis and endometriosis. She is at a high risk of developing cardiovascular as well as cerebrovascular disorder. And even if the patient conceives, she is at risk of developing all problems like placenta previa, abruptio placenta, IUGR, sudden intrauterine fetal death, and miscarriage rates are high, ectopic rate is high, and as well as preeclampsia rate is high in this group of patients. Next, Pallavi, would you want to show the MCQs?
Yes, ma'am. I'm just sharing my screen. Yeah. My screen is visible, ma'am?
Yeah, it's visible. Yeah.
Yeah.
Which of the following limitation is most characteristic of revised ASRM classification system? It cannot be used during surgery. It is poorly correlates with the pain severity and fertility outcome. It cannot classify ovarian endometrioma. It does not include the peritoneal lesions. Which is the correct answer? Next. Yes. So it cannot correlate with the pain severity and fertility outcome. So go to the next question. Which of the following correctly represents the compartment classification in enzyme system for DIE? Peritoneum, ovary or rectum, rectovaginal septum, uterosacral and rectum, ovary, bladder and ureter, and then tubes, ovary and peritoneum. Compartmentalization, which is ideal. Deep infiltrative endometriosis. Correct answer is next slide, please, Pallavi. Correct answer is B, rectovaginal septum, because it is in the posterior compartment. Rectovaginal septum, uterosacral, and the rectum. Next question. Which of the following parameters includes endometriosis fertility index? AMH level, semen parameters, duration of fertility, and serum estradiol.
Harshini ma'am, Uma ma'am, you can unmute yourself if you are answering because you are on mute.
Arshini?
Duration of infertility.
Okay.
AMH, semen parameters are not included. That is the reason you told that EFI
It has to be revised.
revised.
Limitation, rather it is the limitation.
Limitation.
Okay, go ahead with the second answer. Next question. Okay, then next. Which of the following is not a component of updated enzyme? Peritoneum, ovary, tuber ovarian condition, and sigmoid.
Sigmoid colon, ma'am. S.
Correct answer is?
S, D. It's
Yes.
not a component. Sigmoid colon is not a component. For that, it is F. Intestine far lesions are component in the intestine.
Next question. AGL classification system introduced in 2021 differs from earlier systems primarily because it focuses on imaging, pain severity, surgical complexity, operative difficulty, and hormonal status.
It mainly
Correct answer is
surgical complexity
and
operative difficulty.
yes. Okay. Next question is, which classification system combines historical, surgical to generate a score predicting reproductive outcome?
EFI.
RSRM, NCR, endometriosis fertility index, and AAGL classification.
EFI. EFI, ma'am.
EFI.
Endometriosis fertility.
Fertility. Yes.
Yes.
Next question. Global prevalence of endometriosis among women is approximately 1 to 2, 5 to 7, 10 to 15, 25 to 30%.
10 to 15%.
Next question. What is the approximate diagnostic delay from onset of symptoms to diagnosis of endometriosis in India? 1 to 2 years, 3 to 5 years, 8 to 10, 15.
10 to 15 years.
Correct answer is C.
8 to 10.
Next question. Which is the most common subtype of endometriosis in Indian women? DIE, superficial peritoneal, ovarian, and then adenomyoma. Next, Pallavi. It is ovarian endometrioma.
Okay.
But again,
Adenomyosis. Adenomyosis in India.
adenomyosis, but among the endometriomas, it is given most common subtype of endometriosis. They have not included adenomyosis. Then
Okay,
ovarian endometrioma should be the common. That too, again, there is a regional variation. In the eastern side, DAE is more common. In the southern side, it is ovarian endometrioma. Next question. Which autoimmune disease has been associated with endometriosis, myasthenia, systemic lupus erythematosus, Parkinsonism, and hemophilia?
systemic lupus erythematosus.
Yes. I think which dietary factor is associated with increased risk of endometriosis? High intake of fruits, high intake of vegetables, omega-3, and high red meat consumption.
High red meat consumption.
Yes. Next question. One major limitation of retrograde menstruation theory is that retrograde menstruation never occurs in normal women. All women with retrograde menstruation develop endometriosis. Retrograde menstruation occurs in many women, but some develop endometriosis. It explains the distant endometriotic lesions.
It's C, ma'am.
C. The correct answer is C. Retrograde menstruation occurs in many women, but only
Some
some
develop.
develop. This is because of the genetic predisposition. All women have retrograde menstruation, but only 10 to 50% they develop endometriosis. That is because of their genetic predisposition, plus there is increased MMP levels in these women. Next question. If stem cell theory proposes the endometriotic lesions may arise from only ovarian surface epithelium, bone marrow derived progenitor cells or endometrial stem cells, myometrial cells, and cervical stromal cells. Correct answer is
B, bone marrow derived progenitor.
Bone marrow derived.
Yeah. Now I can see Dr. Sheila Mane. Madam, welcome. Just we have few questions. After that, you can deliver your okay. Yeah. Next question. Which growth factor plays a key role in angiogenesis in endometriosis lesion? TGF-beta, VEGF, PEGF, and EGF.
It's B,
I think
VEGF.
everybody is familiar with VEGF. The correct answer is vascular endothelial growth factor. Okay. Then the next question is endometriosis is primarily considered as a progesterone-dependent estrogen-resistant disease, estrogen-dependent progesterone-resistant, androgen-dependent estrogen-resistant, androgen-resistant, and progesterone-dependent. Quite confusing, but it is the answer is very clear.
Yes. B, estrogen-dependent and progesterone-dependent and
progesterone-resistant. Pallavi, you have any more questions with you?
There is one question. I've just WhatsApp you.
Okay. Yeah. Okay, it's all right. We'll limit with this. Now you show me the CV of Dr. Sheila Mane. I think we have already discussed. So the last one is which of the following cytokine is commonly elevated in endometriotic lesion? IL-6, IL-3, tumor necrosis alpha, and all of the above. Which is the correct answer?
All of the above.
All of the above. So thank you all the participants. And now I request Sheila Mane madam to say a few words.
So congratulations, Dr. Ramani. I can see that you're really, getting involved into this subject, endometriosis, and I can say we call you as not only national but now international lady of endometriosis. So nice, because it is really a thing which is on the rise and we see more and more. And recently we had a certificate course also. So sorry, I'm joining late. It happened that I had 3 at a time today. That is, we had Foxy Jogi, then we had IMS also, and this also. So thank you for inviting me, and I wish all the best. I know you have planned a very well program, which will go on, and the modules are very nice. I have gone through it, and I'm sure that those who register will definitely benefit. So once again, congratulations and best of luck for your future programs also. And thank you for inviting me.
Thank you, madam. Thank you so much. So finally, let me, on behalf of Endometriosis Society India, I thank all the faculties, Chairperson Dr. Uma, speakers, Dr. Hepzibah Madam, Ashika, and Dr. Harshini, and all the members who have joined this. And plus, I will be failing my duty if I am not thanking the Olympic Pharma, especially Miss Pallavi, who has been behind me to get this. And I'm very sure soon from the next program, we'll be getting the ICOG credit points, because I had certain issues in getting the credit points. But the subsequent series of webinars we are planning will be having the ICOG credit points. And again, I thank all the participants, Dr. Suranjan Chakravarti, Saktiruba Madam, and everybody, Dr. Pradeep Sir, and Dr. Bhaskar Pal and Dr. Sheila for having given us their blessings. Pallavi, do you have any questions?
Ma'am, one question I have WhatsApp. That's the only question we have received. So there is no question apart from that. So
One question you have WhatsApp me.
Just a minute. The question was, good evening, everybody. I come across a lot of endometriosis cyst in the late teens and at early 20 years in my place, Srinagar. What could be the reason of such an increase in cases? The doctor is from Srinagar. Yeah.
That is from Srinagar. One Dr. Tazeen had asked. It's a very good question indeed. See, now there are two things. There is apparent increase. Probably we know that the disease, we are diagnosing the disease based on the symptoms, and we don't depend upon the imaging or laparoscopy. That may be one reason where we are able to pick up the patients in an early stage. And also the endocrine disruptors and all the other earlier age of menarche, prolonged cycles, and the dietary variation, all those things are going to have a major issue. So the main thing is we are able to pick it up at a very early stage. Previously, if a patient comes with the dysmenorrhea, generally the family members will say it is dysmenorrhea will go when you are getting married. But we know progressive dysmenorrhea means the patient has got the underlying endometriosis. So this may be only an apparent increase in the incidence of the endometriosis, which has been there for quite a long time. Okay, if there are no more questions, can we call it for the day?
Yes.
Thank you so much.
Thank you, ma'am. Thanks a lot. Thank you all the faculty, and I'm sure this was just the beginning. It's a first session from our side, and we have 12 sessions going ahead. All sessions, all modules will be very informative, and it will be useful for all the doctors in their clinical practice. So with this, we can thank you all the participants and the doctors. Thank you very much from the Alcare Pharmaceutical.